But it's also the beauty of the paradigm that it is a meeting point between pharmacology and psychology, and the therapy element should not be neglected, and it's about embracing that model.
All right, so I'm standing here with David Erritzoe, you're a principal investigator, right, at Imperial College London, and yeah, really happy to see you here.
Good to see you again.
Yes, we saw each other at ICPR actually. Yeah, we got some words and wanted to see if something has updated since. How is it with the psilocybin studies on Imperial right now?
Yes, at the moment we are sort of finishing anorexia nervosa trial with psilocybin. Some data will be presented here. I think Robin apparently just already mentioned
Right.
some of them. We are later this year finishing a chronic pain trial with psilocybin as well. The preliminary data will also be shown. Some of the data will be shown on Friday in a talk here. So those are the most progressed of the current trials with psilocybin. We have in the past done depression work. We're not doing depression trials right now with psilocybin. We are, together with Small Pharma, have completed with DMT instead. We are undertaking OCD. We are a third into the trial, OCD with psilocybin. And then we will be, maybe end of the year, start opiate addiction with psilocybin. So that's the clinical studies we are doing at the moment.
Wow, so there's a lot of different diagnoses. What would you say is a common factor with these diagnoses?
Yeah, that's a good question. I mean, maybe sort of an internalized state where you're sort of trapped in specific habits and thought processes that can be shaken and broken and softened up. Some very behavioral, very habit driven, some more ruminative and obsessive. But these sort of internal trap state is shared, I would say, between a lot of non-psychotic conditions in mental health. So that, I think, is a key sort of shared factor that might be well targeted by psychedelic intervention.
Yeah, right. So how can psilocybin help with these stuck-up behaviors?
Sort of to reduce modularity, to reduce this separation of brain function, to soften strict stock patterns in brain activity and thought processes. That's what we see also in the brain data. And it and maybe sort of soften priors, soften top down, allow for some bottom up impact on the brain, the hierarchy of the brain being sort of challenged and somewhat diminished under psychedelics, and that might allow new directions for behavior and thought, and sort of shake it up and allow for change in a positive direction.
Okay, cool. Do you have any preliminary results from these trials with anorexia and OCD?
Not OCD, we don't have any preliminary data yet. Anorexia, looking good, and there we are really close at being done. So that looks very promising. But it's I don't know exactly what the colleagues are going to show off the data, so I don't want to reveal anything wrong here. I'll allow them to present that later at the meeting. But yeah, it looks good.
Okay, super nice. And one last question: where do you see psilocybin in 10, 15 years? Do you feel like it will go into the clinics and go out into healthcare, or will it be longer time before we can see that?
I think that's where it's heading. Psilocybin primary indication will be resistant depression, and as you are aware, Australia has now opened up for implementation already before those trials are complete, in a monitored sort of program in Australia, and the trials will maybe be complete with approval within the next 2 to 3 years with psilocybin for resistant depression. And then how will they be sort of ruled out? How will they be implemented into healthcare? That will take a while and be complicated. It won't be first line treatment. I mean, in sort of it's logical if it's for resistant depression mainly. And you will obviously have all these that we all know, specialized clinics and trained therapists involved in the work, and have that implemented into health systems will be difficult. Another thing is the cost and the size of the efficacy. How will that make regulators decide on whether it will be provided and offered on public health, and time is out. We don't know. We can see that Spravato, ketamine, was not, for instance, being endorsed by NICE guidelines, and would the same thing happen? That's a UK thing, but other countries, some countries, lean quite heavily on decisions by NICE guidelines. We don't know. I mean, so yeah, there's so many different factors into that decision making, and but hopefully it will be strong enough to be implemented so that it can reach broadly patients suffering, including patients who don't have access to expensive private clinics.
So just a follow-up question on that, psychedelic therapy as it's being done today might be an expensive treatment with a lot of therapist hours. What are your views on that? Will that be a problem?
Yeah, it will be a problem. But it's also the beauty of the paradigm that it is a meeting point between pharmacology and psychology, and the therapy element should not be neglected, and it's about embracing that model. But yes, it is a bit of an expensive model. And that also speaks into the commercial space of how to for companies to actually make business out of it. Obviously, a lot of companies are trying that, but it's not easy. It's not straightforward, because it is just a model that I think is going to be a little bit difficult to spin gold on for commercially, and might be tricky to have implemented. But I mean, now that's the pessimistic hat. But I really hope it will be possible. Then you have, some things you can tweak. Obviously, group approaches, which will reduce costs somewhat, and also can increase the volume and flow of patients through. You have short experience psychedelic interventions. You have companies trying to develop a shorter MDMA. You have DMT already existing and showing really good results as well, similar to psilocybin. And that's just a 30-minute session. I mean, the session itself is longer, but it's significantly shorter than a psilocybin 4 or 5 hour oral session. So those things are really interesting to see where they go, because they might reduce the cost somewhat.
So you were in that line of groups, like doing the psychedelic experience in groups to reduce costs. Do you see any more benefits doing it in a group setting?
Yeah, we can see Communitas, as we have published on from our lab, and others are seeing the benefits. We also know it for talking therapy, groups therapy and so on, that it carries challenges, but a lot of interesting benefits for the group dynamics. And also there's this community thing about psychedelics that exist and have existed for long time outside the medical field, and trying to use and exploit some of the beauty in that, I think, is valuable. You have in addiction services, conventional addiction services, you have peer support, you have group relapse prevention groups and so on. And some of that in a psychedelic version should be and could be and will be, I hope, implemented into the treatment model, even in a conventional public health system, which in a way is also not very costly, and will be, I think, powerful and important. But it's not that there's much evidence and how to formalize that and how to do that, but it's not starting from scratch, because it's something existing already, that you have communities and groups and integration groups, also peer support led and so on, that I think will be important to explore and implement into the model.
Thank you so much, David.
Thank you. Thanks for having me.